करने के लिए दूर दूर से जुड़े हैं। कस्तूरी रंगन जी।
Hello. 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 Hello, ma'am. Hello. Hello. Hello.
Hello?
Yeah. Hi, ma'am. Behalf of Dr. Georgie, I want to know, want to check whether the PPT is working properly. Can you able, can I check it? Hello. Nobody is responding. Hello. Hello. Not responding. Hello. Hello. No comment. Hello. Can you hear me? Can I share the PPT? Can you able to see the PPT, sir? Please respond. Oh God, how can I know? Hello. Hello.
Yeah, hello.
Please
Swaha.
respond, sir. Hello, sir.
Yeah,
Yeah,
yeah, we can listen. Yeah.
I want to know the PPT is working well or not before
Yes,
we
yes, yes.
start.
It's working, and we
In the
can hear your sound also,
in
and the
the
PPT is full screen.
uh,
Perfect.
right. Okay. Thank you.
Yeah. Hi, can I check my PPT?
Yes, yes,
Yeah, I'm sharing the screen.
yes,
Huh?
yes, yes. You can share
Wait.
your screen.
Yeah,
First, you have to open your PPT in the background, and then.
yeah. Are you able to see?
No, no, we cannot see any slide.
What do I do now?
You have to open PPT in the background. Okay,
One
and
minute,
then.
1 minute. Totally open. Slideshow.
No, no. Share slide. You have to come back on Zoom page.
I've come back on Zoom
Zoom page.
page.
Go to the bottom. In the
Ah,
bottom, you'll find one
yeah,
icon. That is share
yeah,
slide.
yeah.
Okay. You can
Okay.
click on the share.
Now,
Yes, perfect.
perfect.
Yes, yes. Now you can do
Oh,
full screen and
yeah. I'll
yeah,
just do full screen.
yeah. Yes, yes. Now we can see your entire presentation.
Okay.
Yes, yes.
Okay. I'm closing.
Okay, fine. So anyone else would like to share and do test run? Any other participants, any other speakers would like to share? Just to cross check. No, madam, you can end slide and show. So
Oh,
you
one
have
minute.
stop sharing
No,
slide. So at
I'm
the
minimizing.
no, no, that will not help. You have to go to the share screen, no, where you have
Go.
done share screen at the top of the what do you say screen. One more
You
option
are
will show.
screen sharing. Yeah.
Uh,
Stop share.
yeah, stop share. Yes,
Okay.
perfect.
Fine.
Now you have exited the sharing. Okay. So this is how we
Yes.
have to share and stop stop sharing screen.
Okay. Okay.
Okay.
Good afternoon. Can you hear me and can you see me? Hi, Dr. Bhuvneshri.
Hi, Dr. Madan.
Yeah. Hi.
Yeah.
Hello, Dr. Georgie. Good afternoon. Yeah. I think you're muted, so I cannot hear you. Yes. Yeah. Professor Dr. Samad, good afternoon. Sazida, yeah. Very nice to interact with you, Sazida Kashim, madam. I think Indian Diabetic Association is very, very pleased to collaborate with the Bangladesh Academy of Dietetics and Nutrition. Um, in fact, you'll be very happy to know that India won the bid to host the AFDA, the Asian Federation of Dietetic Association Conference 2026. So we are going to be hosting it in India, in Mumbai. And in fact, we are very keen this time to have a virtual IdeaCon 2020 in December. And we want to take all our Southeast Asian countries with us for this IdeaCon, so that, we strengthen these bonds and this connect, and it will go a long way. This kind of an exchange, academic exchange, is very, very meaningful.
मैं आ रही हूँ मैम एक सेकंड.
So I think I'm very grateful to Curie Hospital.
नहीं दिख रहा इधर से.
I think Swaha, who's the person who's from Curie?
Ma'am can speak from here.
Yeah. Okay. Swaha is here. She's the one who facilitates. So how is Bangladesh in terms of COVID? I think you all are muted, so I can't hear anything. You have to unmute yourself, sir.
இல்ல இது எடு கவர் எடு. ठीक है मैम हो गया. कवर एड.
So you can't unmute. Okay. I think they've done it centrally. Okay.
How to do that?
ஹலோ
ஹாப்பி ஈவினிங் மேம். நான் மோகன் பேசுறேன்.
யாருங்க?
ராமின் மேட்ரிமோனில இருந்து கால் பேசுறேன்.
இம்மா நான் ஒரு வெபினார்ல இருக்கேங்க. பாய்.
A very warm welcome to all the delegates from Philippines, from our neighboring country Nepal, especially from Bangladesh. A very warm welcome to all of you to this International Renal Nutrition Update 2020. So this webinar is to empower dietitians with evidence-based nutrition so that they can take it to their daily clinical practice and improve their outcomes of their patients. So this webinar is organized by Curie Hospital and by the Indian Dietetic Association as well as the Bangladesh Association of Dietetics and Nutrition. So first we have Gayatri Ananthakrishnan from Curie Hospital. She is the Managing Director of Chennai Urology and Robotic Institute. She has been instrumental in building up this institution, and she's very keen in providing quality healthcare by adopting the best clinical practices. She's very passionate about creating a difference. She leads various social initiatives like the Indian Prostate Cancer Foundation and the Foundation of Dementia Care Foundation, so which helps to transform the quality of life and dementia care for patients as well as their families also. So Gayatri ma'am, can you speak a few words?
Thank you. Good afternoon, everybody. I take great pleasure in welcoming you all today for the International Renal Nutrition Update 2020. It's said that when God closes one door, He opens up another door. And I think these pandemic times have been really challenging for all of us. But there has been an upside to it as well. The thing is, I think there's a problem. Is there a problem?
The audio is not clear.
Sorry. So I think that has been pandemic time. As I said, the pandemic times have been really challenging for all of us. And the upside of it has been the distances have been made shorter. And sharing of knowledge has been made really easy because in those days, I mean, a few months ago, sharing of knowledge has been where we had to travel to meetings to meet eminent people. But now it has all become virtual. And sitting in our home, sitting in our office, we are able to rub shoulders with eminent people across countries. So, and constant updation of skills gives us a better confidence. With this in view, the diabetes department headed by Ms. Swama of Curie Hospital, along with, we're very happy to associate ourselves with the Indian Dietetics Association under the leadership of Dr. Jagmeet Madan. And Madan, I congratulate you because you were just saying that we won the bid. India has won the bid to host the Asian Dietetics conference. I mean, that's such a huge honor. Congratulations, I feel very proud. And we're very proud to associate ourselves with Bangladesh Academy of Dietetics and Nutrition, Mrs. Satila Kashi. Thank you very much for giving us this opportunity. And at Curie Hospital, just give you a little note on Curie Hospital, Chennai Urology and Robotics Institute Hospital. It's a super specialty hospital dedicated to treatment of patients with renal diseases. We specialize in we hope to be one of the existing thing that we've been trying to develop for hospital is that, I mean, it is the fact that most of the renal patients are on diet restrictions. And the most common complaint with patients with renal diet restrictions are that food is tasteless. Salt restriction mean food becomes tasteless. So our dietetics department, along with the chef, the canteen team here, have been trying to put together something called Renal Diet Made Tasty. And we started the Curie Renal Diet Canteen, which supplies healthy food with all the diet restrictions, but tasty food, not only to the patients here, but we also deliver home food after the patients go back after their surgery, post-surgery. It's a concept that we've been trying to develop on it. Success of any conference or any meeting, however well we take efforts to arrange it, always depends upon how depends upon the eminent speakers. And I think today we have succeeded in that because we have a star-studded faculty. Professor Dr. M.A. Samad, Professor and Head of the Department of Nephrology in Anwar Khan Modern Medical Hospital and College and Hospital, Dhaka, Bangladesh. We are very honored to have you with us, sir, today. Welcome. And our own senior nephrologist, Dr. Georgie Abraham, Director of Nephrology at Madras Medical Mission. Thank you, sir, for being with us today, and our respects to you, sir. And Dr. Bhuvaneshwari Shankar, Vice President and Chief Group Dietitian of Apollo Hospitals Group. I think with such a star-studded faculty, the session today is going to be absolutely fantastic. And another important point is about the participants. And I think the number of participants today have almost reached 1,500, I think very close to 2,000. And I think that is very huge. And welcome you all. And I hope you enjoy the session as much as we hope you enjoyed putting this together. And soon after the pandemic times, I think we are all able to meet. All is well with virtual meetings, but I still think meeting in person would be, it has to charm. So we would like to welcome you all to all our friends in Bangladesh. We welcome you all to Chennai, and we hope we are able to host technology for students. Thank you.
Thank you, Gayatri ma'am. I would like now invite Dr. Jagmeet Madan ma'am to give the welcome address. Before that, I would like to introduce all of you Dr. Jagmeet Madan. She is an eminent nutritionist, National President, Indian Dietetic Association. She is the principal and professor at SNDT Women's University, Mumbai. She is a gold medalist and a recipient of Young Scientist Award and Dr. Ravanathan Award by the Nutrition Society of India and National Nutrition Institute of Nutrition, Hyderabad. She is a recipient of prestigious International Research Grant Award from the Academy of Nutrition and Dietetics. She has also received the Best Teacher Award by SNDT Women University, Mumbai. She is a lead principal investigator of the International Research Project on pre-diabetes in adolescent and young adults in India and food-based intervention approved by USDA. She is also a lead investigator in a multi-centric pan-India project on school-going children in collaboration with Diabetes Foundation of India and World Diabetes Foundation. She is also a lead investigator in Tanita Health Link project with the Ministry of Japan. She was the mission leader of the Joint Review Mission of Ministry of HRD Government of India in the evaluation of the midday meal program in the state of Maharashtra. She is an expert on the FSSAI scientific panels on labeling and advertisement. She is a member of the National Steering Committee of NetProfan FSSAI Government of India. She is a certified master trainer of Project Hope, which is a diabetic educator project in India by the IDF, and she's also the author of the Indian Manual. She is a part on the National Expert Working Committee on Asian and Indian consensus statements and guidelines on obesity, diabetes, cardiovascular disease, physical activity, and gut health. She has more than 50 publications in the international and national peer-reviewed journals and books. And she's also a regular columnist in the various magazines. She's a very dynamic leader for the Indian Dietetic Association. I welcome you, ma'am, to give the note of welcome address to all the delegates.
A very good afternoon to one and all. Thank you, Swaha, for this wonderful introduction. I bring greetings to you from Indian Dietetic Association. Let me say, right in the beginning that Indian Dietetic Association stands tall with close to 20,000 life members and 25 chapters across India. IDA, Indian Dietetic Association, is committed to not only generating evidence-based science, but has been very actively associated, especially in the recent times, in the dissemination of factual information to not only the scientific fraternity, because today we are talking about the importance of nutrition in the light of COVID-19, and there are so many areas which have emerged wherein nutrition plays a very, very important role. So I think the entire, family of Indian Dietetic Association, which includes the National Executive Committee members and the chapter conveners across India, have come together to kind of disseminate the evidence-based factual information to all stakeholders, be it government, be it industry, be it the people at large. And I'm very happy to share that a lot of our resources are on national portals, FSSAI, My Government portal, and also on the IDA website. And we have given a lot of emphasis to reach to the common man to impart correct knowledge at this time when people are looking for the right kind of information. So we've gone local, we've gone vernacular, and we've done all that bit from the association. Today I'm extremely heartened, especially for the fact that IDA takes pride in collaborating with the prestigious Chennai Urology and Robotics Institute, Curie Hospital, and who has brought us together with the Bangladesh Academy of Dietetics and Nutrition to host the International Renal Nutrition Update 2020. Friends, I take this opportunity to share the good news that Indian Dietetic Association has won the bid for the Asian Federation of Dietetic Association, and we will be hosting the AFDA conference in India in Mumbai 2026. But prior to that, as a prelude, IdeaCon 2020, which we are going to host in December, we are going to make it like a curtain raiser, wherein we want to connect to all the Southeast Asian countries virtually and make IdeaCon 2020 an international conference. So I was extremely happy when our chapter convener of Chennai approached me and we said that we are collaborating with Bangladesh Academy of Nutrition and Dietetics. So this is maybe the first step to connecting threads. And I'm sure the delegates who are listening to us are from various Southeast Asian countries, and I could see some of them are from Pakistan and Nepal. And so, friends, we want to connect more with our fraternity in all these countries, and the exchange of scientific information, the clinical experiences. I think these are very, very meaningful collaborations, and this probably being the first one. And like I said, good things have to begin. So we are going to take it forward from here. And talking about the theme of today's conference, I think we all know diabetes. India is a diabetes capital, and 80% of the cases, the CKD cases, are with diabetic nephropathy. And then, talking about that, talking about renal transplant, I think these are very, very important areas to deliberate. And like Madam Gayatri said, that it's a challenge to meet the requirements for a renal patient and yet make the diet very palatable and acceptable. So I am looking forward to the deliberations by Dr. Georgie Abraham, Professor Samad, and my own colleague, Dr. Bhuvaneshwari Shankar, with whom I've interacted at various forums. So I'm extremely excited to be a part of a very fruitful academic deliberation. So once again, thank you. I think IDA Chennai chapter. I'd like to mention the name of Mr. Krishnamurthy, Ms. Meenakshi Bajaj, and who were really, facilitators for IDA coming together for this conference. Thank you so much for this opportunity.
Thank you so much, ma'am. I would also like to welcome Mrs. Sazeda Kazim Jyoti. She is the Executive Director of the Bangladesh Association of Dietetics and Nutrition to speak a few words. Ma'am has been a nutritionist and a health education officer at Diabetic Healthcare Center, BIHS Hospital. She has also been at the Cardio Care Specialized and General Hospital, Uttara, Dhaka. She has also served as a renal dietitian at Gono Shastalaya Dialysis Center, Dhanmodi, the largest dialysis center in Bangladesh. So she served a lot of renal patients under her. She is also the director and trustee of Bangladesh Stroke Association. She was a professor at Herman Jemna College. She is also a young iconic entrepreneur among the nutritionists and dietitians. A brainchild of hers is the Bangladesh Association of Dietetics and Nutrition. So she's also a very popular mentor among the dietitians and nutritionists over there. Her initiative brought the interest to become a specialist in the specific sector in dietetics and nutrition. She's a social activist associated with various social health services. I would now welcome you, ma'am. Mrs. Sazeda Kasim, ma'am.
I think she
Can you unmute yourself?
Unmuted.
Now. Am I audible? Hello, am I audible?
Yes, madam, you are audible.
Okay, thank you so much. Good afternoon, everyone. Assalamu alaikum. It's a great pleasure for me and my colleagues to be a part of this program. It's really a big honor for us to share the platform with Dr. Jagmeet Ma'am, National President IDA, and Dr. Georgie Abraham Sir, also a renowned nephrologist from Bangladesh, Professor Dr. M.A. Samad Sir, and Dr. Bhuvaneshwari Shankara Ma'am. I'm also grateful to Curie Hospital and IDA Chennai chapter for arranging such wonderful program. Special thanks to Krishnamurthy, convener IDA Chennai chapter, Ms. Swaha Chattopadhyay, clinical dietitian, Curie Hospital, and Ms. Reshma Alim, EC member of IDA Chennai chapter, for taking such a wonderful initiative. Now I'd like to share a few words about Bangladesh Academy of Dietetics and Nutrition. It's a government registered organization working in the field since 2012. It was formed with objectives to improve the nutritional status in the rural and urban communities, to improving the access to equality nutrition services, prevent diet-related NCDs, strengthening coordination and partnership who serve the same purpose, providing necessary professional skills of nutritionist and dietitian and other health workers. Also trying to contribute in the field of research with updated tools and techniques. BADN is the only organization of its types in Bangladesh. BADN organized several seminars and workshops in collaboration with local and international organizations. More than 400 juniors, fellows, and professionals were trained successfully, and most of them are occupied with different national and international organizations. Several certificate courses are newly announced, which may also scope the nutritionists and dietitians to choose the specialized sector for them. We hope in future our collaboration with will sustain to do more activities for the betterment of health care seekers and providers. So now I am humbly requesting everyone both countries to join this wonderful webinar. And thank you so much for this wonderful initiative. Thank you.
Thank you so much, ma'am. Without further delay, let's move on to the next session. which is Nutrition and Metabolic Management in Pre and Post Transplant by Dr. Georgie Abraham, sir. And the moderator of the session is Dr. Iday Chandran, sir. He is a nephrologist at Curie Hospital. He has a special keen interest in acute renal failure, continuous renal replacement therapy, and renal transplantation. Over to you, sir.
Good afternoon, everybody. I welcome one and all to this webinar, International Renal Nutrition Update 2020. It's a privilege to welcome Dr. Georgie Abraham, sir, to give his valuable insights on post-transplant malnutrition. Dr. Georgie is a stalwart in nephrology and needs no introduction. He is the Director of Nephrology, Madras Medical Mission Hospital, Chennai. He has received numerous awards for his contribution to the field of nephrology, countless. He has around 262 publications to his credit. He is the founder and trustee of TANKER, Tamil Nadu Kidney Research Foundation and Kerala Kidney Research Foundation. He is the pioneer of CAPD in our country. I welcome Sir Dr. Georgie Abraham to share his knowledge on post-transplant malnutrition.
Hello.
Hello.
Hello. Hello. Can you hear me?
Sir, we can hear you. You can proceed, sir.
Yeah. Okay.
We welcome you, sir.
You can hear me?
Yes, sir, we can hear you.
All right. Good afternoon. And at the outset, I want to thank the Curie Hospital organizers, IDA, and Bangladesh Society of Dietetics and Nutrition, and distinguished colleagues from India, from Bangladesh, from Pakistan, and from Philippines. And it's a great honor for me to join with you. And at the same time, I would also say that we face enormous challenges in managing patients with chronic kidney disease who are not on dialysis, who are on dialysis, and after transplantation. So I would dwell predominantly on malnutrition after transplantation. And I'm sure that I feel very comfortable that Dr. Bhuvaneshwari is there, as well as Dr. Samath, my close friend. And I have spoken with Dr. Samath in Bangladesh, Dhaka at different times. So this is the outline of my talk: pathophysiology of malnutrition, nutritional assessment and requirement, adverse effect of malnutrition, and longitudinal data from India. So definition of malnutrition. Malnutrition refers to deficiencies, excesses, or imbalances in a person's intake of energy and or nutrients. The term malnutrition addresses three broad groups of conditions: undernutrition, which includes wasting, low weight for height, stunting, low height for age, and underweight, low weight for age. Micronutrient related malnutrition, which includes micronutrient deficiencies, a lack of important vitamins and minerals, or micronutrient excess. Overweight, obesity, and diet-related non-communicable disease such as heart disease, stroke, diabetes, and some cancers. Next. So just to jog your memory, the normal nutrient composition, you don't want a wasted patient. You want somebody who is smart and nice like this man, and you don't want an obese patient. So the macronutrients are proteins, amino acids, carbohydrates, lipids, water, and micronutrients are vitamin, minerals, and macrominerals and microminerals, and they include calcium, chloride, magnesium, phosphorus, potassium, sodium, sulfur, and then chromium, manganese, iron, copper, zinc, selenium, molybdenum, and a lot of other things. Carbohydrates provide about 4.1 kilocalories per gram, proteins 4.1, and fats 9.3 kilocalories per gram. So, do we see malnutrition only in the body shape? No. Hair, nails, and skin differentiating cutaneous manifestations of micronutrient deficiency. So, micronutrient deficiencies commonly lead to cutaneous abnormalities involving the skin, the hair, the nails, and these cutaneous manifestations often provide clues to the existence of the underlying deficiency, which could be B complex vitamin, which could be fat soluble vitamin, or minerals. So this cartoon shows you the energy expenditure kilocalories per day. The kilocalories are shown on the vertical axis, and you have the energy expenditure here. The green one is basal metabolic rate. You use 60 to 75% for basal metabolic rate. Physical activity 15 to 30. Diet induced is 7 to 13, and others are 2 to 7. This is where you increase or decrease your energy expenditure. There are a number of transplant patients who are weightlifters who take part in competitive sports and games, and also in swimming, and also who are marathon runners. So they're depending upon their physical activity, they have to increase their energy intake. Healthy subjects energy requirement ranges between 35 to 40 kilocalories per kilogram body weight, depending upon the physical activity. So this is just basic. Fat and muscle tissue play different roles in metabolic homeostasis. The body contains water, 20% is extracellular, 40% is intracellular, fat is 15%, protein is 15%, and minerals are 10%. The fat is the energy storage. Compartment volume depends on the energy intake. And protein, 60% of the proteins are in the muscle. Visceral protein is 20%. Connective tissue is 15%. Remaining protein are 5%. The muscle, tightly regulated protein compartment, stores glucose as glycogen. So 60% of the body is water in a male and about 50 to 55% in a female. Now, are Indians different from Caucasians? Normal waist circumference for an Indian men is 90 centimeters, or for Indian women are 80 centimeters. I am sure that this applies for Pakistan, Bangladesh, and other South Asian countries. This waist-hip ratio for men is 0.88, and for women it is 0.81, and normal BMI for Indian is 18.5 to 23 kilogram per meter square. Now, this is a publication which we recently made in Indian Journal of Transplantation, Malnutrition, Kidney Transplantation, our experience and review of the literature. So a comprehensive patient-specific dietary and lifestyle plan made in collaboration by the patient's treating physician, skilled nutritionist, because they are the most important rather than a nephrologist, and the family and the patient's socioeconomic background. So these are the important components of looking at a nutrition status in a patient with chronic kidney disease and those after transplantation. So is dietary discretion important after transplantation? Major benefits of organ transplantation is an end to the dietary restrictions imposed by CKD and CKD dialysis. But this false perception is in the minds of both patients and physician that after a transplant they can eat everything they want, which is their false perception. So post-transplant diet education is very important, starting immediately after transplantation. And I respect my nutritionists because I have been dealing with nutritionists and engaging them in my patients all the time. So they should be ensured an adequate energy and protein intake, medications and nutrition related side effects, food safety and sanitation, therapeutic diet as needed, not. Initiate a program of graded physical activity to reduce muscle atrophy and assist in weight control. So the nutrition status determines clinical outcome in patients. Weight gain, obesity, dyslipidemia, post-transplant diabetes mellitus are commonly encountered. Obesity is a risk factor for renal graft loss. Prevalence of undernutrition in transplant recipients, its effect on the outcome of kidney transplantation are underestimated. Nutrition management, important across all three phases of transplantation, including pre-transplantation, acute post-transplantation, and long-term post-transplantation. The pathophysiology. Changes in body composition after transplantation are due to increased appetite, and they eat all sorts of food, reversal of the uremic state, steroid treatment, in particular immediately after surgery. We need to use steroids or immunosuppressive therapy, lack of physical exercise. This leads to accumulation of fat mass, alteration in the fat distribution, and muscle wasting. Excess body weight predisposes to changes in the metabolic status, leading to hypertension, cardiovascular disease, insulin resistance, heart dysfunction, and glomerular hyperfiltration. So sorry about this busy slide. Nutrition assessment for the transplant candidate: history, comorbid conditions, medications, diet history, nutrition intake adequacy, gastrointestinal issues, food allergies, dietary intolerances, weight history, functional status. This is all being done by a trained nutritionist. And then biochemical parameters are albumin, pre-albumin, which we don't usually do unless there is a research program going on, C-reactive protein, blood glucose levels, hemoglobin A1C to look at the diabetic control, ferritin, transferrin saturation, hemoglobin, PTH, 25-hydroxy vitamin D, calcium, phosphorus, potassium, and lipid profile. The anthropometric and nutrition-focused physical findings, which is done by a trained nutritionist, include body weight, height, weight changes, percentage of standard body weight, body frame size, BMI, waist circumference, waist to hip ratio, fat distribution, tricep skin fold thickness, muscle wasting, micronutrient deficiencies, and this can be done by a subjective global assessment or malnutrition inflammation score. So this is what we do in our institution. We have a BCM, which is being done regularly on transplant patient, both peritoneal hemodialysis and also in transplant patient. This is a BCM. And then mid-arm muscle circumference, skin fold thickness, and also hand grip strength. We do that in all our patients. And this is the Harpender's skin fold calipers we use. And also we have a lot of publications, and I will show you that on DEXA. DEXA is very expensive, but we have been doing it some 10 years ago, and I will show you some data on that. So in essence, you have food intake and you have losses. So food intake, we can look at the stores by anthropometry, serum albumin, DEXA, and bioimpedance analysis. Losses by NPNA, protein nitrogen accumulation, and then anthropometry will give you the SGA, subjective global assessment. Diet recall and symptoms also will help you to do that, and functional state by hand grip strength. Now, association of pre-transplant albumin level with post-transplant outcome in kidney transplant recipient. When you look at that, this is American data. You look here, the hazard of combined outcome. And then the serum albumin is shown on the horizontal axis. So you can see that when you have a reasonably good serum albumin, 3.5 to 4 and 4.5, your hazard ratio for worse outcome is less. As the albumin falls, which is a sign of malnutrition or inflammation, your chances of combined outcome is higher. So this is another article which we published in 2015. Is there a genetic predisposition to new onset diabetes after kidney transplantation? This is by Yogesh Reddy. He's a staff at the Mayo Clinic right now. And what we have seen is that in conclusion, there is a genetic predisposition to new onset diabetic mellitus and transplant related hypertension in South Asia seen by the HLA association, and predisposition exists to the individual diabetogenic effects of tacrolimus and cyclosporin, which are important immunosuppressive agent based on the HLA type. This could lead to more careful selection of calcineurin inhibitors based on HLA types in the South Asian population. Now, when you look at the pre-transplant glycemic control with that the outcome in diabetic kidney transplant recipients, here it is shown the hemoglobin A1C. This is American data of 2,872 long-term dialysis patient who underwent renal transplantation and were observed over 6-year observation. So as the hemoglobin A1C increases, the hazard ratio for mortality increases. So it is imperative and important that the dietitian should engage with the patient, the family, and the nephrologist to take care of the diabetes of the patient so that their hemoglobin A1C is kept between 5.5 and probably at less than 8. So association of pre-transplant serum phosphorus, and we shows that you have the log hazard ratio, the pre-transplant serum phosphorus. So when the pre-transplant serum phosphorus is between 4.5 to 6.5 or something, you have the least hazard, and compared to when the serum phosphorus is high pre-transplant. So this tells you that mineral bone disease and its implications on the cardiovascular system may exist even after transplantation when the patient's phosphorus level is high, uncontrolled. So malnutrition inflammation score and mortality, it shows here malnutrition inflammation score, and majority worse malnutrition, higher patient death and graft loss. So weight gain and weight loss in transplant patient, receiving a transplant with a body mass index of over 25, higher incidence of new onset diabetes mellitus, wound complications post-transplant weight gain, diagnosis of undernutrition. Undernutrition can be diagnosed if an individual meets 2 of the following 6 criteria: insufficient energy intake, unintentional weight loss, loss of muscle mass, loss of subcutaneous fat, localized or generalized fluid accumulation that may sometimes mask weight loss, and diminished functional status, or when the BMI is less than 18.5. So pathophysiology of weight loss post-transplant may be due to the kidney dysfunction, associated metabolic acidosis, the bicarbonate level less than 22 millimoles of bicarbonate, sepsis, acute concurrent illness, psychological factors such as depression, socioeconomic factors, and inadequate dietary prescription. So nutrition management of renal transplantation can be divided into several phases: the pre-transplant period, during the transplant surgery, early post-transplant period, late post-transplant period. So these are the important things, and one should look at. So I'm just showing you an example of one of our patients, 54-year-old patient who undergoes a deceased donor transplant. The parameters are shown. The transplant was done on 4/12/17, and you can see the serial parameters here: weight, BMI, BCM, intracellular water, extracellular water, total body water, bone mineral content, mid-arm muscle circumference. And when you look at that after the transplantation, definitely there is an improvement, all that. And when you look at her BMI, it was 18.9, and after the transplant, the BMI went down to 17.7 immediately after the transplant. So this is a factor which was concerning for us. And let me show the next slide. So this is a protein in the body. This was done with a BCM, loves soft lean mass, skeletal muscle mass, fat-free mass, and percentage body weight, mineral content, face angle. So you can see that the face angle, the normal values are 6.5, and after the transplant, there is a change in that. So this will help us individually in each patient to look at the body status after the transplantation. So daily nutritional recommendations post-renal transplantation, immediate post-transplant period and acute rejection. It should be late post-transplant and all phases. The major nutrients are calories, protein, fat, zinc, fluids, and then we have to look at lipids, and then we have to look at fiber, sodium, potassium, phosphorus, calcium, iron, magnesium, because a lot of our patients have hypomagnesemia, which is a side effect of calcineurin therapy. So I regularly monitor their magnesium and supplement magnesium. I have patients up to 15 years who have been regularly taking magnesium. Then vitamins, water-soluble vitamins, and vitamin D3. So nutritional recommendations for the pregnant transplant recipient. I'm sure that once in a while you encounter that. Caloric intake should be 25 to 35 kilocalories plus 300 calories daily in the second and third trimester. Protein should be 1 to 1.2 gram per kilogram plus 10 to 25 grams of protein. Micronutrients same as for a non-transplant pregnant lady. Prenatal vitamins are advised, especially in the early pregnancy. Folic acid intake should be at least 400 microgram daily. So nutrition consideration during acute rejection. Acute rejection, optimal protein and calorie intake is the primary nutritional concern. High dose steroid produce a dose-related increase in protein catabolic rate, leading to catabolism. Protein intake should be 1.5 gram per kilogram body weight is appropriate. So energy metabolism, real, this was something which we published in 1997. I'm sure that many of you know, Varsha. And what we found is that it was in transplant situation. Many patients see the sudden freedom from dialysis as lifting of the burden of dietary restrictions, and binge eating of favored food is common. It is usual for weight gain to be maximal in the first 6 months and stabilize subsequently. So malnutrition, this is another paper which we have done, I think, and fasting hyperhomocystinemia, we observed in 56% of the patients, hyperlipidemia in 48% of stable renal transplant recipients. Follow-up after treatment with statins, supplemental folic acid, B6 and B12 reduce hyperlipidemia and serum homocysteine levels. So this is, sorry about this busy diagram. Sonali is now a consultant in America, critical care, Sonali Mandu. We did this paper, and what we were looking at is 109 post-transplant patients. So you are looking at the BMI less than 21, 21 to 25, 26 to 21, over 30, and in the age of the patients are shown here, who are the transplant patients. So majority of the patients with a BMI of less than 21 were in the age less than 30, and you can see the age difference there. So BMI, fat distribution and percentage as measured by DEXA scan, as well as the prevalence of type 2 diabetes mellitus in our transplant population revealed a significant positive correlation with age. So can EGFR, body mass index and smoking predict renal allograft survival in South Asian patient? Ashik is a radiologist now, and we did that. I'm not showing the details, but the conclusion was serial EGFR, body mass index, smoking are predictors of graft survival because following renal transplantation in South Asian patients. So higher body mass and decrease in EGFR and smoking reduce the survival. Utilizing this information, interventions must be initiated to improve the outcome of patients with renal transplantation. So this is another paper done by Gokul Ramani. He is doing his fellowship in the United States. What we found was using the DEXA in 249 patients, males were 150 females. What was the conclusion? 10% had normal BMI, 62% were pre-obese, 21 were class 1 obesity, 5% were class 2, and 2% were class 3. Metabolic acidosis, 30% of our cohort at bicarbonate level of less than 22. Mean hemoglobin was 10 grams and LDL was 90 plus minus 31. So this is, so the serum albumin level, I'm just showing you the vegetarian less than. When you look at here, you can see that the vegetarians serum albumin level was lower compared to the meat-based people here. So difference is shown there, and this is a serum albumin. I'm not going into detail depending upon the BMI. So food safety, prevention of foodborne illness, transplant recipients are 15 to 20% more susceptible to foodborne illness than the general population. Hand washing, sanitation, safe food temperatures, food preparation, and the source of drinking water are very important for transplant patients, despite immediate post-transplant period or late post-transplant period. So food safety, herbal supplements, we do not know, they lack safety. Efficacy, you know, we have heard during the corona, COVID-19, there are so many supplements being provided. Are they safe in post-transplant patient? We are not sure. So please don't advise these things. Nutrient drug interaction are very important, especially tacrolimus, cyclosporin, and sirolimus. As you can say here, grapefruit, pomelo, sevile orange, pomegranate, and star fruit, they can all interfere with the immunosuppressive effect of tacrolimus, cyclosporin, sirolimus. They inhibit cytochrome P40 and CYP3A4 isoenzyme and P-glycoproteins. I'm not going into the details of this figure. So medications, cyclosporin, tacrolimus, sirolimus, methotrexate, mycophenolate, and corticosteroids, they have their own, as I already alluded to, adverse effects, hyperglycemia, hypomagnesemia, hyperglycemia, all these things. And so we need to look at that, and steroids producing hyperglycemia, hypokalemia, increased appetite. So a nutritionist, a trained nutritionist should know the side effects of the immunosuppressive drugs when they are getting advice from, when you are giving the advice to the patients and their families. So conclusion, I would like to conclude by stating that identify the role of nutrition care throughout the transplant process from assessment to education. Distinguish the specific nutrition needs for subpopulation. Discuss criteria supporting a diagnosis of malnutrition and discuss specialized nutrition lifelong. And thank you for this great opportunity. I hope that you will have some questions. I'm looking forward to that. Thank you.
Thank you, sir. It was enlightening. It was a not so discussed topic, particularly malnutrition post-transplant. It was a very enlightening talk.
Thank you, sir. We will move on to the next section, which is diabetic nephropathy, role of diet and lifestyle modification. The moderator of the session, Koyal Pal Chowdhury. She is a certified diabetes educator, PhD scholar in critical care nutrition in IPGMER and SSKM Hospital, Kolkata. Ms. Koyal Pal Chowdhury, can you introduce the speaker of today?
Yes, I'm audible.
Hello?
I'm audible. Hello, I'm audible.
Yes, you are audible.
Thank you so much. Good afternoon, everybody. I am Koyal Pal Chowdhury, research dietitian in IPGM and SSKM Hospital, Kolkata. A representative from BATN, Bangladesh Academy of Dietetics and Nutrition. We are united to sustain and support the field of food science and nutrition, and as well the dietetics practice in Bangladesh. Eventually, it is extending collaboration with national, international recognized bodies for professional development like Indo-Bangla Venture. Their main agenda is to highlight each dimension of nutrition and propagate the contribution of nutritionists and dietitians in the society. Overcoming all the shortcomings, knowledge, and the practice gap, the BATN is now executing all the essential enforcement to step into the heights in near future with all your support and blessings. Today, one more feather is added as BATN is attached with Curie Hospital Chennai and IDA Chennai chapter. I feel so privileged. So I'm coming into our topic of discussion is diabetic nephropathy, which is the key cause of CKD and end-stage renal failure. Diabetic nephropathy, which is the dynamic consequence of diabetes and is very prevalent of any of the diabetic patient, yet very complicated to handle, as there are lots of trials and errors in disease management, nutritional guidelines, lifestyle modification and counseling, and variable approaches in each stage of disease progression. It's very hard to cure, we all know that. But prevention and control can be achieved with proper intervention. In fact, from a dietitian perspective, I can say that diabetic renal chart preparation is very critical and totally different from the diabetic or simple renal diet chart. So for resolving all our queries, updating ourselves with new knowledge and recent guidelines, I would like to invite a very eminent speaker from Bangladesh and a very renowned nephrologist, yes, Dr. Professor M.A. Samad. He is MBBS, MD in nephrology, FCPS in medicine, and FRCP also. He is professor and head of the department and chief consultant in renal and all urological diseases in Department of Nephrology, of Anwar Khan Modern Medical College and Hospital. He is pioneer in Bangladesh. His work is also enlightening because he established the interventional nephrology in Bangladesh, like ultrasonic guided kidney biopsy, subclavian hemodialysis catheter insertion, and so on. Not only that, he is president of Kidney Awareness Monitoring and Prevention Society Bangladesh. As well, he is the president of Bangladesh Society of Peritoneal Dialysis. He received so many awards and recognition throughout the world for his contribution in practice and research. So no more wait. I'm welcoming you, sir. Over to you. We are really looking forward to your session. Thank you.
Thank you very much for your nice introduction. I also extend my heartfelt thanks to organizer, especially Jagmeet Madan, Gayatri Asta Krishan, and Shazada Kashan to give me the opportunity to such an excellent platform. It is a great opportunity that in this meeting I could meet George Abraham. Actually, I miss him very much, especially in this day of COVID, because we met several times in different occasions, and also he visited Bangladesh several times and encouraged us to establish CAPD and other site of nephrology. I also extend my thanks to all the speakers. All are legends of the country and in the subject, and it is a great opportunity to learn from them. My topic is diabetic nephropathy, role of diet and lifestyle modification. Actually, this is a very important topic. I will go through a few points. Then first one is the global scenario of diabetes mellitus. We know the main cause of end-stage renal failure is diabetes. It is globally, and initially in developing country, GN was the primary cause. Now it has turned that main cause of kidney failure is diabetic nephropathy. And if we look towards the scenario of diabetes pattern globally, we see that in 2000, the global estimate of adult diabetes was 151 million. By the end, it reached into 285 million. That is 88% increase by this time. And currently, the number has raised to 463 million, and 63 million, yes, right? 463 million who are aged 20 to 79 years, and also additionally 1.1 million children and adolescents will be added to these with type 1 diabetes mellitus. If the number is projected to 230, the number will be 578 million, and while for 245 the number will be 700.
Samad sir, can you kindly increase your volume?
Volume or yes, is there? Can you hear me, please? Hello. Hello. Hello.
Yes,
Can you hear me? Diabetes mellitus in Bangladesh scenario, almost 10% adults have diabetes, the prevalence had increased substantially from 5% in 1995 to 2005, and nearly 10% in 2006 to 2010. In this time, it has become doubled. IDF stated that the prevalence will be 11.4 million by 2030, and by the end of 2045, it will be 15 million. Can you hear me, please?
Yes, sir, we can hear, sir.
Okay, thank you. And now I like to show the pattern of diabetes in different countries. Here are 10 top countries with the number of diabetes patients. At the top is China, then India, and at the bottom now Bangladesh. But the number of population is highest in the China, then India. And if we see the pattern, how it is increasing. In China, we find that in 2019, the number is 116 million, and 2030 it will be 140, and while in 2045 it will be 147. And India now 77, and it will be 101 in 30, and in 2045 it will be 134. So there is a rapid rise of diabetes. And but if we look at the United States, we will find that at present it is 31, but after 11 years it will be increased by 4 million only. And after another 15 years, it will be increased only 2 million. 2 million only. That is almost stable, their number. But in what we see in our Asian countries, the number is jumping. Also, if we look at Germany, it is number 8, and it will next in 30 it will be on the 10th position, and they will go down and go back from the top 10. It will leave the top 10. But in Bangladesh, now, if you look at Bangladesh, it is 8. Currently, the number of diabetic is 8.4, and it will be 11.4 in 2030, and it will be in 45 it will be 15 million. But our population is 170 million. So the rise of diabetes pattern, the trend of rise is vivid in Southeast Asian countries and as well as Asian countries in comparison with Western developed countries. Why such difference? America, there is rise is very little, but in Asian countries, especially South Asian countries, the trend of rise is so rapid. Why this region? Perhaps here is the reason. This is practice of lifestyle and as well as dietary practice, healthy dietary practice. In Bangladesh, previously, if we consider diabetic nephropathy, previously glomerulonephritis was the preeminent cause of diabetic nephropathy. But currently, we see that diabetes is the main cause of diabetic nephropathy because the number of diabetes patients is rising rapidly. And we have one study we have found that our from type 1 diabetic patient, 40 to 50% diabetic patient develop diabetic nephropathy in their lifetime, and 20 to 30% develop diabetic nephropathy in type 2 diabetes. I would like to go briefly about natural history and then pathophysiology, so that we can gauge how can we prevent such rapid rise of diabetic nephropathy, as well as we can prevent end-stage renal failure, development of end-stage renal failure. We can see here patient first attacked with diabetes, then no nephropathy. But gradually what happened, from no nephropathy to microalbuminuria, next step macroalbuminuria, and next is elevated plasma creatine, this renal failure, and finally end-stage renal failure. But if we look at the outcome, when patient has no nephropathy, if the death rate is 1.4, but when microalbumin it becomes 3%, and while macroalbuminuria it becomes 4.6%, but once there is renal failure, the rate of death increases up to 19%. So diabetic nephropathy, it is dreadful for the patient with diabetes. If we look at the diabetic nephropathy, it is very busy slide, but I like to show one thing. What is in the center for the development of diabetic nephropathy and diabetic kidney disease, and which factor we can control. If you look, you can see here visceral obesity, but central obesity is the main cause. From here, there is dyslipidemia, there is insulin resistance. Insulin resistance again increase hyperglycemia. There is sympathetic overactivity, which also increase hyperglycemia, high blood pressure. RAS activation, which increase, which causes hypertension. Kidney compression, which causes mechanical damage to the kidney, as well as hemodynamic pressure on it. So finally, if we look what happened here, in this pathophysiology, we can see that if there is overweight, there is obesity, this will finally aggravate the condition of diabetic nephropathy. And initially, these conditions will favor for the development of diabetic nephropathy. First, by diabetic, if we see this lipidemia, it will increase the oxidative stress, which give rise to the inflammation and ultimately causes glomerular damage. On the other hand, this RAS activation, SNS activation, this causes hemodynamic instability. There is increased blood pressure, increased glomerular pressure, ultimately which causes glomerular damage. Hyperglycemia itself causes glomerular damage by different way, mechanical way. So by this way, once there is visceral obesity and patient is diabetic, and these may lead to diabetic nephropathy. Here we can see normal glomerulus. Here is the afferent arteriole, and this is the efferent arteriole. But in case of diabetes, we can see the dilatation of afferent arteriole. There are many causes of this dilatation, mainly during diabetes, there are increased glucose as well as sodium in the proximal tubule, and finally, with glucose co-transporter, these are reabsorbed, and this dilute fluid comes to the macula densa, and interaction with macula densa and glomerulus. This a complex mechanism. This causes this vasoconstriction of afferent vessel, And due to this vasoconstriction, there is increased glomerular pressure. At the same time, there is efferent arteriolar this vasodilation and efferent arteriolar vasoconstriction. This led to increased interglomerular pressure, and due to this interglomerular pressure causes hyperfiltration, and due to this hyperfiltration, there is a complex cascade of effect. Ultimately, this complete one arm there is hemodynamic insult, other way metabolic, another is inflammatory, and another arm there is fibrotic changes due to this hyperfiltration. And these different way leads to transcription factors, and finally this causes glomerular hypertrophy, mesangial expansion, tubular interstitial disease, glomerular sclerosis, and kidney fibrosis. Ultimately, this lead to diabetic nephropathy, and finally diabetic kidney disease and end-stage renal failure. No, sorry. What are the risk factors? If we look at the slide, it is also a busy slide, and we found that there are many risk factors which include age, demography, sex, race, and hereditary. We have no hand on this, but there are modifiable factors. These factors also they cause a susceptibility to diabetic nephropathy, and initiation of nephropathy, and progression of nephropathy. And these important factors are hyperglycemia, obesity, hypertension, and also smoking, dietary factors, and high protein intake. So all this come to the lifestyle, and our present lifestyle giving the birth of diabetic nephropathy due to uncontrolled and unhealthy lifestyle. Next. Now I'd like to go to the our main topic. Main topic is one diabetic nephropathy and diet, and other one is diabetic nephropathy and lifestyle. In this few slides, I will try to show you some relation between diet and deterioration of renal function. And if we control our diet, and if we can teach our patient, if we can educate our community people about diet and healthy lifestyle, they can prevent the renal failure. Here, the high prevalence of multiple metabolic derangements in patients with diabetic nephropathy. A diet should be modified based on culture, disease severity, blood pressure, phosphorus, and potassium levels. Patients with eGFR more than 60 ml per minute need no any dietary modification, but patients with eGFR less than 60 will need dietary modifications. These include patients with GFR less than 60, the potassium intake should be guided by serum potassium level. Calcium intake usually 1000 milligram per day, but sometimes it is recommended up to 150 milligram. Maximum phosphorus intake should be 0.8 to 1 gram per day, even if the serum phosphorus concentration is normal. The dietary phosphorus should be derived from sources of high biological value, such as meats, eggs, etc. But in pulses and other lentils, there is phosphate, but this is the second same class type of protein. That is why we prefer to take less amount of such vegetable as well as lentil proteins. Maximum calorie intake should be 30 to 35 kilocalorie per day. Maximum fat intake should be less than 30% of daily energy intake, with saturated fat limited to less than 10% of energy. And daily fiber intake should be around 15 to 38 gram per day. Protein intake. We know in diet there is relation already we have shown. If there is increased protein in the glomerulus, this causes hyperfiltration. So there are many trials about low protein diet, and some trials showed this retards the progression of renal failure, but other argue that the low protein causes malnutrition. So on a few slides, we'll see what amount protein we should take. In non-nephrotic patient, if GFR less than 60, daily protein intake should be around 8, but it can be reduced to 6 gram per kg per day without any malnutrition. A modest restriction is generally well tolerated and does not lead to malnutrition in patients with diabetic nephropathy, and metabolic acidosis should be avoided because metabolic acidosis causes protein catabolism as well as protein malnutrition. Here, in modification of diet in renal disease study, MDRD study, patients treated with protein restriction and greater choline GFR in first 4 months, followed by somewhat slower progression. Here we can see, here there is protein restriction from here, and this is the months in time and the cumulative choline GFR. Here, this indicates if protein is restricted in diabetes, what we see there is hyperfiltration, increased interglomerular pressure, and increased GFR. And this restriction prevent this hyperfiltration by lowering GFR, and at the same time reduce GFR. And this GFR reduction is not harmful. So it is concluded that protein restriction is helpful to prevent glomerular damage by hyperfiltration. Here one interesting paper, though the number of patients was low, Linnea Garneta, she has given very low protein diet, supplemented with keto analogs, seems nutritionally safe, and could defer dialysis initiation in some patients with CKD. So with keto analog, very low dose protein can be tolerated. What do in low protein diet in prevent malnutrition? If we are giving a low protein diet, what we should take care? Patient with diabetic nephropathy, low protein diet should be carefully monitored and with close follow-up every 3 to 6 months for adequate calorie intake and evidence of protein malnutrition. We should see every 3 to 6 months. 3 conditions must be met with to avoid malnutrition. One is adequate calorie intake must be maintained. At least 60% of ingested protein must be of high biologic value and or contain high percentage of essential amino acids. Stimulation of skeletal muscle protein breakdown should be prevented by controlling metabolic acidosis. And a patient with nephrotic syndrome, there is some study and they have found in nephrotic syndrome, if protein is restricted, liver continues to synthesize low level of albumin, and in them patient may suffer from protein malnutrition. But in other studies, author suggested in the nephrotic syndrome, protein can be restricted to the level like 6 to 0.6 to 0.8 gram per kg, but the loss nothing happened. Can you hear me, please?
Yes, sir.
Hello. Any problem?
No, sir.
Okay. If there, then sodium intake should be less than 2 gram. That means the total sodium chloride 5 gram. And patient with the reduced eGFR who do not have hypertension, they can take a bit more. So that is 2.3 gram sodium. That is 6.75 gram of sodium chloride. And very low sodium, sometimes it may be harmful because if the sodium is very low, it may cause hyponatremia. On the other hand, if sodium is taken more, then it may cause hypertension. And so sodium cup should be U-shaped. That is, the range should be sodium chloride. It is 2.3 to 5 gram is best sodium chloride for every patient. But if it is patient has hypertension, it should be a bit lower. Here it has been shown that if sodium is restricted, this is baseline study, and here you can see the control group, and here patient has this is the sodium. This is diastolic pressure. This is control group, and this one is test group. And after sodium restriction for 12 weeks, it has found that in control group, the diastolic systolic pressure is same, but in test group, it has reduced to 8 millimeter of mercury. So sodium restriction controls blood pressure to some extent. Benefits of low salt intake. Diabetic nephropathy, in case of diabetic nephropathy progression, very low. Few studies have examined the effect of salt restriction on diabetic nephropathy progression. Compared with those with a low salt intake, less than 100 milligram milliequivalent per gram urinary sodium creatine excretion, the risk of progression of end-stage renal failure was greater with high salt intake. Here we can lower the blood. This sodium, low sodium can lower blood pressure, slower progression of end-stage renal failure, and improve cardiovascular outcome. We should control potassium. I am going a bit rapid because I think time is a bit short. Potassium intake should be taken by examining the potassium level, and then calcium intake Also, it should be taken around 1500 milligram, but it's better to take 1000 milligram per day. And administration of calcium containing phosphorus binder should be avoided, because if calcium containing binder is given, it causes vascular calcification, especially cardiovascular calcification, and increase cardiac death. Phosphorus intake should also be restricted, and even the level of phosphorus is normal, yet additional phosphorus should not be given. And phosphorus containing diet, especially tin or processed food, this should be avoided. In case of diabetic nephropathy, carbohydrate intake. Patient with, we have already told about protein intake that should be reduced, and now carbohydrate intake. The patient with GFR less than 60 ml per minute, the calorie intake should be 30 to 35 kilocalorie per kg per day, and fat should be restricted to less than 30%, especially saturated fat should be less than 10% energy intake. Higher body mass index and central obesity are independent risk factor for end-stage renal failure, cardiovascular events, and mortality. Fiber intake should be 15 to 38 gram per day. And already we have come towards the end of my talk. Here is the lifestyle modification. This is very important part of my talk. Physical activity, we know the physical activity improves physical fitness, blood pressure, lipid profile, insulin sensitivity, and cardiovascular outcomes in persons with diabetes. Cross-sectional and longitudinal studies have shown that high prevalence of diabetic kidney disease in individuals with low level of physical activity. However, only a few clinical studies have examined the effect of physical activity on diabetic kidney disease. Here we can see the leisure time physical activity, and at the end, cumulative progression of renal disease. Here we can see the leisure time, that is, leisure time means when we are not doing our professional jobs. So we can do sports, or we can walk, or we can do any physical activity. So here it has been shown that a relation of deterioration of renal function is only with intensity of physical activity. It is important because someone is cooking and they are telling, yes, we are doing work whole of the day, and some person is doing official work, and they are telling, yes, we are doing official work, so we are working, we are doing exercise. But this exercise will not help to prevent the deterioration of renal function. Only there is correlation between deterioration of renal function and progression of and intensity of exercise. Here it has been shown during 8 years of follow-up, the cumulative progression rate was 15.4% in case of low activity person, low intensity group. Whereas the deterioration was, prevention was only 5.9% in case of
Sir, can you wind up the session?
Sir.
Okay.
Sir, can we wind up the session?
Hello. Just we have come to the end of the, towards the end.
Yeah, because it's lack of time also.
Okay. So we should continue our physical activities, and we have seen in many studies that physical activities retard the progression of renal failure. Smoking, there is good relation between smoking and albuminuria. Also, cessation of smoking prevents such albuminuria. There are many studies. There is a relation between obesity and renal impairment, renal injury. Obesity has the multiple health risks, including hypertension, cardiovascular disease, obstructive sleep apnea, as well as osteoarthritis. There is obesity was directly related with mesangial expansion sclerosis, as well as focal segmental glomerulosclerosis. And central obesity is the main harbinger. And we have come to the end. And finally, in conclusion, I like to tell that diabetic nephropathy is the main cause of end-stage renal failure globally. The rising trend of diabetes in this geographical area is alarming, especially in Southeast Asia. And development and progression of diabetic nephropathy are closely associated with dietary habit, lifestyle modification, including physical activity, dietary habit, weight control, etc. For the prevention of diabetic nephropathy as well as of its progression, healthy dietary habit and healthy lifestyle is crucial. Prevention of epidemiology of diabetes. To prevent epidemiology of diabetes, we must educate the general people about kidney disease, about healthy diet and healthy lifestyle. And with this conclusion, we like to say that kidney camps, that's Kidney Awareness Monitoring and Prevention Society, working for last 16 years to create awareness among the rural people about kidney disease and its harmful effect and how to prevent it, and by different medical camp as well as World Kidney Day Roundtable and rally in different way. So I had the opportunity today to talk to you, and in the future we can make collaboration with such association and institution with you, and we can further strengthen our activities to aware the people, and we can share our knowledge about such prevention. Thank you all. Thank you again to give me the opportunity to talk over here.
Thank you so much, sir.
Thank you so much, sir.
Thank you so much. And we also wish to collaborate with you in future. And we are so happy to see the extensive work you do, sir. Now I would like to invite Dr. Jagmeet Madan ma'am to introduce the
Yeah, can you hear me? I think we'll request. Okay, am I audible?
Yes, ma'am.
Okay. So, friends, I have the great pleasure and privilege to invite the next esteemed speaker, Dr. Bhuvaneshwari Shankar. Dr. Bhuvaneshwari is the Vice President, Dietetics and Group Chief Dietitian for Apollo Hospitals Group, which has close to 54 hospitals. She has a very large experience of 32 years, and I think she has been an integral part of Apollo Hospital, and she has been extremely instrumental in raising the nutrition standards in the hospital. Her expertise is in the field of clinical nutrition, with her doctorate and her specialized area being critical care nutrition. And she's come out with publications on clinical nutrition. It's a manual for adults and pediatrics. She's also accredited as to be the faculty for European Diploma in Clinical Nutrition, which is organized by ESPN. She's a real sought after speaker at national and international forums. And today she's going to talk on a very, very interesting topic, considering that, maintaining the nutritional status of a CKD patient is the biggest challenging job of a nutritionist or dietitian. So she, being a dietitian, she is going to tell us about how to motivate the renal patients to nutrition adherence in pre and post renal transplant. So over to you, Dr. Bhuvaneshwari. I look forward to your talk.
Thank you, Dr. Madan. Thank you, the organizers, for inviting me for this lecture. I'm going to take not more than 15 minutes since we are running out of time. The topic given to me is motivating the renal patients in nutritional adherence, the toughest job which is expected of dietitians. I'm not going to go in detail about the recommendations or the stages of CKD. I'm just putting the slide to you to show even in US at different stages malnutrition is there in CKD patients pre and post-transplant. Dr. Georgie has already spoken. I'm not going to talk much. And there are a lot of causes for protein energy wasting in CKD. Number one is dietary restriction in the list. There are so many reasons, but false, self-made, self-proclaimed dietary restrictions are more. Patients listen to a milkman, a maid, or a neighbor, or anybody they listen to the minute they get kidney disease more than listening to the dietitian. So definitely the dietitian has a big role to play in the nephrology field. I am proud to say I started my profession as a nephrology dietitian even before joining Apollo Hospitals way back 35 years back. So I learned from the nephrologist regarding the diet. So our basic work is assessing the nutritional status, providing the appropriate indices for the medical nutrition therapy, nutrition counseling, which needs to be individualized, educational materials to be prepared according to the patient's needs in their language, monitoring nutritional status, and adhering to the diet and medications. Usually patients will hear from everybody, they'll be thoroughly confused, and patient's family, the minute patient is diagnosed to be having kidney disease, they will start restricting everything to make already the intake poor. Patient is already worried about his disease, and they think by stopping salt his kidney function is going to improve. So the family will also start dumping such food, making him more a patient. So if you look at Espen, Kedoki, everybody has told what is a role of a dietitian with regard to kidney disease management, but a skilled, trained dietitian who is proficient in the assessment and evaluation of the nutritional status and development of nutritional care and diet prescription is what is required. Nutritional assessment, like any other disease, anthropometric, biochemical, dietary, I'm not going to talk much. So diet plays an important part in the treatment plan. Elements of renal diet, already we have heard enough: sodium, potassium, phosphorus, fluids. Its restrictive diet is a challenge for patients. Diet compliance is poor. Palatability is a big issue. How many of us have tasted a food without salt? How many days can one sustain food without salt? The art and the science behind, we need to learn the art to make the food tasty and first clear the myths from the patient's mind. Formulation of the renal diet is relatively very complex compared to planning other modified diets. If you look at studies, CKD diet compliance, renal diets are arguably the most restrictive for any patient group, and many of the restrictions contradict current recommendations of healthy eating. Diet compliance issues, if you look at it, 20 to 75% patients are non-compliant. Why? But if the compliance is shown, it's increased the quality of life, life expectancy, medical complications will come down, risk of symptoms will come down. How do you convince a patient? First and foremost, We all need to understand why restriction, what are the restrictions. We have already heard sodium so much, potassium so much, phosphate so much. How do we learn to transform this into a menu which a patient can follow? And there are so many things about potassium restriction, so many different ways of following the restriction. Some say leach, some say don't leach, some say boil the vegetable for so many times, throw the water out. Finally, what are we giving the patient? Is it palatable? First of all, how much is the patient eating? How are you going to make him improve? What are the different sources of potassium? What are the medicines which give potassium? What are the medications which
Dr.
have
Bhuvaneshwari,
potassium
I'm
sparing things?
Dr. Bhuvaneshwari, I'm interrupting a little bit.
Yeah.
I think there's a problem. People cannot see your slides. Can you share your screen once again?
Should I?
Please do that, because
what should I do?
They
You
can't
are
see the
screen sharing. That's what it shows.
No, it shows, but in the chat show, everyone is saying they can't see the slides. So if you just
is it okay now?
No, I think you just come out of it and then share the screen once again. Do that.
Just a minute. Stop share. I'm giving.
Stop share and
now
then start again.
Share screen.
Yeah.
Okay. Is it okay now?
Yeah.
I've again shared. Is it okay?
Yeah. Now
we can hear.
Is it okay?
Yes.
Okay. So should I go back to the previous slides or start with this?
Yeah, because a lot of them missed your slides. Yeah. Thank you so much.
Yeah. Sure. So different stages of CKD and malnutrition, causes of protein energy wasting, role of dietitian in nephrology field. What does Yespen say? What does Kedoki say about role? Again, I'm telling any fresh dietitian, if you're not sure about your diet, do not confuse the patient, because the patient gets thoroughly confused. Already he hears from many people, stop salt, your kidney will improve. It's not so. Each person, after so many years of experience, I do not start counseling a renal patient without the diet prescription from the doctor. Because does everybody need fluid restriction? No. Does everybody need salt restriction? No. Salt restriction, again, the quantity which is prescribed is different from person to person. So sodium, potassium, phosphorus, and fluid restrictions, and renal diet is highly restrictive. Compliance is poor, but if they follow the diet restrictions, they can delay the initiation of dialysis, pre-dialysis patients. Okay, and though we say 35 calorie per kg or so many grams of protein per kg they need, if you calculate exactly what the patient is taking, it's very sad. Most of them don't even get half of their requirement. And again, about restriction on potassium, there are so many myths and patient is thoroughly confused. First, dietitian should be clear on her knowledge so that she can learn to impart that knowledge to the patient. And we need to understand which are the foods which have more potassium. What is the potassium prescribed to a patient? How are you going to translate it into the diet? And many patients, you have to ask a question, what salt are you using? They think low sodium salts are good for them. But we have to understand low sodium salts have high potassium salts in it. So we need to explain to the patient, if you're allowed 2 grams of salt, it's ordinary sodium chloride. Do not take a low sodium. So one of the questions which we need to ask when we take the history is, what are you eating? How much are you eating? What salt? Are you measuring your fluid? All this. And star fruit, already doctor was talking about this fruit interaction post-transplant, but this fruit is having a property to cause renal function in patients who take it much more because of its content, its nephrotoxic effect it has. Okay, so protein restriction, the source of protein, animal versus plant protein, how much quantity, what are the sources? If you look at it, more plant-based protein may slow kidney function decline. This is the latest paper in Australia. There are papers saying plant-based proteins are better. But how is the quality of protein. So we need to understand what is the patient's eating habit and then change. If a person is an animal protein eater, how much quantity should we allow? There's no need to stop anything. uh, First understand what he's taking and tweak his diet. What are the challenges in maintaining good nutrition? Anorexia due to decreased taste and smell of food. There is another study which is published, very, very latest. It's not yet even gone for publishing. I'll show the paper. Nausea, vomiting. This not because of food, maybe urea creatinine is high. You have to convince the patient, start taking, following the diet restriction. Urea creatinine will come down in the course of treatment and you will feel better. Palatability issue because of salt and potassium and fluid restriction. We need to teach them what are the other ways they can enhance the taste of the food. And see, this is the paper which I was telling, prevalence of taste changes and association with other nutrition related symptoms in end stage kidney disease. They found that 38% of these patients had taste changes. Imagine your diet is restrictive, your urea creatinine is also causing things, so your taste is different. So you have to tell the patient all this should settle down. So, it's more of counseling and then about diet counseling also. Salt restriction. Already enough is spoken. We need to understand. See, families tends to over restrict. Belief, if they stop salt, kidney function improves. Difficult to follow when one stays away from home. I do get initial stage of CKD people, even young ones, who stay in the hostel, who order food from outside, or they're staying with in a PG. You have to find solution. That's the job of a dietitian. It's not to say take 1 gram salt. How do you make them take 1 gram salt? What are your suggestions? Go through his lifestyle and then suggest. And again, achieving salt restriction in CKD, there are so many barriers for this. So family acceptance, fear that friends will think he has got a disease. How many kidney patients want to say they've got problem? Trouble in shooting foods in restaurants, favorite foods are not low in salt. There are so many reasons. So, it's easy to advise, but we have to make sure that they're able to follow different ways to cut down salt by, if the patient is not diabetic, teaching him to eat something with little more sugar, or making them add something like in a South Indian way, little more tamarind or cooked tomatoes in the gravies, making them, tell them first, your food need not be totally different from the families. Yes, before adding the salt, take the food out and then add the salt on top so that the taste of the salt is there in the mouth. These are the tricks which a dietitian can explain to the patient how to follow. So again, about PEW, there are so many papers about PEW, protein energy wasting. And if you find the quantity of food because of restriction is less, please do not hesitate to suggest oral nutrition supplements, at least for a short while till he becomes a little better, and then we can start. Same way, phosphate. Again, we heard our previous speaker telling patients who are pre-dialysis, diet alone doesn't increase phosphate. Again, the problem with phosphate restriction is it's indirectly restricts protein. So look at the overall diet, and then this can also cause protein energy wasting because his intake comes down. Again, phosphate can come from additives, dietary supplements, and calcium fortification. This is the latest CADIGO practice guideline on diabetes management. I just thought I should show you. Look at what they say. Recommendation. We recommend an individualized HbA1c target ranging 6.5% to less than 8.5% with diabetes, non-dialysis dependent CKD. So hemodialysis, if you look at the malnutrition in hemodialysis, it's worldwide. Worldwide malnutrition is there. Look at India, we have more. 28 to 54% patients have protein energy worldwide. And malnutrition and nutrition intervention, if you understand Protein energy malnutrition, does it respond to nutrition support? Yes. Protein energy wasting, if intake is inadequate, otherwise no. Hypoalbuminemia, not in all cases. Frailty, sarcopenia, cachexia, only, if disease process is treated, cachexia can. So we need to understand why is it. And factors contributing to malnutrition in renal failure, there are so many. See, if you look at loss of protein, even in dialysis, it happens, we need to understand. So nutritional support, they all spoke. It, level of malnutrition, it depends on compliance and spontaneous nutrition intake. First is nutrition consultation, then if required, nutritional supplement, and then if required, IDPN, enteral nutrition, total parental nutrition. Advising dialysis patients to restrict fluid intake when they have not had advice on how to limit their salt intake is inhumane and a waste of time. Both need to be titrated. Same way, phosphate, we need to understand per gram of protein, 10 to 12 milligram phosphate is there. Okay. So nutritional intervention, encourage nutrient, dense food, modify or liberate diet according to individual needs. If patient is not eating enough, if he is allowed 2 grams of salt, look at the total day's intake and allow him one meal, putting all the 2 grams, let him enjoy that meal. Other 2 meals, teach him how to take without salt by adding other, herbs. Food fortification, can we do it? Please think. So do we need a protein powder to fortify the food? Is there any protein syrup which we need to give it as a shot, oral nutrition supplement or hypercaloric oral nutrition supplement? CKD specific oral nutrition supplement, low volume, hypercaloric, low in electrolytes. And see, providing a high protein meal during hemodialysis versus a standard meal, there are papers published. So whenever a patient is coming for a dialysis, providing a high protein meal definitely improves their their biochemical values. So as dietitians, we should plan to give at least one model meal when they come for dialysis. If meal is not inclusive in the package, at least give a high protein snack or an ONS, whatever is feasible. So, providing an ONS which can cover 500 calories in a day is good enough as one. Nutrition support is beneficial in CKD patients. There are number of studies published, the benefits of nutritional support in CKD patients. Renal specific ONS improves albumin levels and mean SGA score. So there are papers published. Providing in-center meals and ONS is the most promising way to increase serum albumin and improve longevity and quality of life in patient populations. Even the guidelines are suggesting this same. Cadigo, Espen, everybody, special formula products. This need not be a formula which is a commercial formula or a scientific formula. If you can create your own, why not? So you need to enhance the oral intake, avoid strict diet restriction with poor intake, offer oral supplements or snacks, treat gastroparesis and other GI maladies. Achieving glycemic control also will improve the intake, correct electrolyte abnormalities, provide food appropriate to the patient's dentition, evaluate for and address depression. Many patients think, lifelong should I follow this? You have to put it this way: if you want a long life, you need to start following. How do we assess our success? Improved overall intake, progression from nutritional support to diet only. See, our aim is not to make them drink all the time. Let them eat, but take them towards eating. Increase intake of specific nutrient to support specific need if there is a deficiency. Reversal of nutrition deficiency symptoms, patient reported symptoms like energy level. I'm feeling better, I'm feeling hungry, my GM symptoms have improved. These are all showing a success. Sometimes biochemistry, but not always albumin. Tools, SGA, patient generated SGA or NFPE. So renal transplant, I'm not going to talk too much because Dr. Georgie has already spoken. Early, late, post-transplant, there are two phases. So usually patients after transplant, soon after transplant, they may not start eating very well, but that time allow them to eat well. At the same time, as they get used to a normal diet, they start overshooting on their, overindulgent on their intake, and they start putting on weight, increase in cholesterol, increase in triglyceride. And because of the immunosuppressants, they also can, the blood sugar level value also can go high. So dietary intervention monthly, they have to come for follow up with the dietitian. So post transplant, we need to look at their weight, their overall intake. Is it going too much? And again, cyclosporin, tacrolimus, medicines can increase their potassium values go high. Do we need to control on their potassium intake? We need to assess their salt intake. Are they overindulging? Cholesterol, we need to check the values. Whenever the patient comes to us for consultation post transplant or pre transplant, we need to ask for the biochemical values to understand what it is. As I said, pre transplant, there may be some patient who are hypo, sodium can be low. The doctor would not have prescribed a very strict sodium restriction. So we need to understand why. Let's not prescribe without looking at the biochemical values, and go by the prescription given by the doctor. If in doubt, please go back and consult with the nephrologist again. So I would like to conclude, malnutrition is there pre-dialysis and post-dialysis. Dietitian need to understand thoroughly regarding the renal diets, post and pre-transplant diets. You convince yourself how you are going to convince the patient. Thank you very much for your patient listening.
Thank you, Dr. Bhuvaneshwari, for a very, very exhaustive and comprehensive coverage of the topic. So, Swaha, do we have a scope of some questions? How are you going to organize the discussion?
Ma'am, due to lack of time, we could not arrange that question answer session, but there is huge number of questions came in our chat box. So what we'll do, we'll send all the questions to our speakers and we'll mail all of the participants the question answer.
Okay, so so you are not taking up any questions now?
No, ma'am. No.
Okay, sure. Fine, thank you.
क्योंकि उधर है ना स्लाइड से इधर स्लाइड शेयर नहीं करना. So we all came to the end of the session. So here we are going to discuss about a case study. We'll share one case like nutrition management in CKD on dialysis. So in the CKD stage 1 to 4, we know we can manage through medication and diet, but when we are coming to stage 5, we need dialysis and proper intervention. For dialysis working here as a life-saving action. So here we can know, as per our all doctors discussed, that the dialysis is increasing in our India day by day. So here my case study, she is a 66 years female with diabetes type 2 and hypertension, and for 15 years. So she is on insulin. So when we received her that time, she came like twice maintenance of dialysis. After received here, we started thrice times of dialysis in a week. So when she came here, we checked her anthropometric details. She had 160 centimeter of height and 67.2 kgs of weight. So we checked her standard body weight because as per KDQI recommendation, we have to check the SBW or AGBW for the nutritional
intervention for that dialysis patients. So that time the SGA was moderately malnourished, patient can't work properly, and patient has moderate wasting of fat and muscle also. After that, what will be our next step? We follow the patient for 6 months, and what we followed for her, to prevent the nutritional deficiency, prevent lean body mass, and maintain the acid-base balance, minimize the nutrition-related side effects, immune function, and surely we have to decrease the risk of infection and provide effective, attractive, and palatable diet. So we give 30 to 35 kilocalorie of energy, 1.2 gram of protein, and 2 to 4 milligram, 2 to 4 gram of sodium, and 2.7 to 3.1 gram of potassium. So fluid what we gave, that will be 500 to 1000 ml per day, and the amount of equal previous day's output. So what the result or the outcome is, we can see the albumin level was increased from 3.1 to 3.7. And nutritional requirement, we gave that 30 kilocalorie of energy and 1.2 gram of protein. And we started high protein supplement, what will be low potassium, low sodium rich also, to reach the proper amount of nutrient. After that, when we did the nutritional assessment after 6 months, we checked there is no edema, and that time also patient weight, dry weight has been increased, and patient was well nourished, and their patient weight is 64 kgs. So here we can, I can show you the last 10 days diet recall. What we can see, we can achieve nearly 80% of energy and protein requirement. As per the lack of time, we run out through it little fast. So if you have any doubt, any query, we can always inform you that through mail. So I would like to thank IDA Chennai chapter and BADN for joining hands with Curie to organize the international webinar on Renal Nutrition Update 2020. I would like to thank specially Dr. Jagmeet Madan ma'am, Dr. Jakaria sir, Mrs. Sajeda Kashim ma'am, Meenakshi ma'am, Krishnamurthy sir, and Koel ma'am for helping us and for taking that good initiative in the very short of span of time. I especially thank Mrs. Resma Ali ma'am. I want to thank the all the speakers, Dr. Georgie Abraham sir, Professor Dr. Sama, Dr. Bhuvaneshwari ma'am. And I would like to thank Mrs. Gayatri Ananthakrishnan, MD of the Curie Hospital. I like to thank entire Curie team, Dr. Ida Chandan sir, our full IT team, and I want to thank Microlab team. So thank you for joining with us. If you have all the questions, we'll surely attend through our mail. Thank you.